So no, so timing of surgery is very important, and only few will talk about. And this is not an uncommon situation where you see fused fingers. So what you require is not only separation, but separation of the web, so that you don't end up with a V, you have a U. So that is one. Separation, so that you don't get a flexion contracture. You create a nail fold. These are the three things that you need to consider when you are seeing these syndactylies. Now the fingers are not of the same size, and therefore they have to be separated early. If you don't, it is to start with soft tissue contracture, it becomes a bony deformities as time passes, and therefore they should be operated early. And when do you do it? Do it in first 2, 3, 4 years, 3 years before they start going to the school. With a gap, if you are doing multiple surgeries, there can be a gap of maybe as minimum of 3 weeks, maybe of 3 months also. So as I said, the digits are of unequal size. Early surgery to prevent deviation of the fingers, because the bones start deviating and this nail folds are shared, and therefore you have to split and create something here. So we had this boy, both the hands were affected, a flap coming on the dorsal aspect, and this is a white base of the flap which is based on the dorsum, and this is going to be used for creation of the first web space on the volar aspect. So this was brought to the anterior aspect. So this has gone on to heal, not with a V but with a U, and the amount of split thickness, amount of full thickness in graft has come from the groin area. You can use a little bit of swing from the hypothenar area also, but in this case it came from the groin area. The next thing is, you make the long cuts on the pulp, on the tip, on the hyponychium, so that now this goes to lie here. So on the another one fold, so it creates a one nail fold, and this skin makes another fold on other finger. So this way you can separate, and now you have been nicely created a fold which is U-shaped and not Y-shaped. Bare area, if you try to close everything fast, you end up getting contractures, and therefore use judiciously reasonable amount of skin graft. Complications: if you don't use generous amount of splint, if you don't use generous amount of skin graft and splinting, they can end up in contractures, and therefore use skin graft and splint to prevent contracture of these patients. Delayed presentation. Look, flexion contracture is occurring because the fingers are fused. This is unequal growth, and you have not treated it primarily. You have treated them primarily, but skin graft has not been used, and therefore now they are developing contractures. One of the problems that has been seen with syndactylies treatment is there's a creeping of this web space, and try to prevent it by keeping some pressure dressings in this area, so that this can be minimized to the maximum. And see also that instead of U, it is forming a V, and therefore this has to be avoided by using generous amount of skin and flaps. Next, to the poorly developed thumb, there are various grades. The aim is either to improve it or change it. Improve it, if something is available, make it better. If it is not worth changing, then worth improving, then change it. So you have a thumb where the thinner muscles are not there, the thinner muscles are absent, they are not there. So you take one of the abductor digiti minimi from the small finger, with going all the way to the proximal phalanx, take it with a tendon and take it across and restore the thinner muscles, and they really do well over a period of time. And when do you do this? Do it early, first year of life. Brain acceptance is much better if you do it in the first year of life. Then there is a group where the trapezium is absent. If trapezium is absent, it is different in the adult where the trapezium is excised. When the trapezium is excised in adult, the thinner muscles are all there, so this is stable enough. Here nothing is there, thinner muscles are not there, stability because the absence of trapezium is there. So in such patient, what you can do is you can take out the phalanx from the feet, and you can transfer it to reconstruct your trapezium. Put a K wire here. Once this heals, one new trapezium is formed. And see, this is donor. Can you make out from which toe we had taken out the graft? So it's almost difficult. Probably it was this, but it is difficult to see where the graft was taken. So this graft, once it heals in place, a thinner muscle is taken, hypothenar muscle is taken, and this muscle with a long tendon graft is allowed to reconstruct and provide an opponent's plasty. Of course, there are situations where the thumb is floating. It has no brain representation. I've seen quite a few of these during my fellowship. That doesn't really work, and therefore this needs to be sacrificed, and index has to be polycized like I'm going to show. This was a 7 months old NRI, and we decided to opt it for a polycization. We dissected out the dorsal aspect, we dissected out the volar aspect, the thinner muscles were the introshia were dissected out. The first metacarpal majority part was separated out, and when this was freed, and sure enough, this was transferred to create a thumb. Attempt at salvage was made in one of the patients where fibula was put in with screws and K wires, and over a period of time you see this is getting absorbed and becomes historical. It is lost, and therefore fibula doesn't work. Toe graft early on in life is good enough. Early on in life, the child that I showed was 8 years old. It has been followed up for a few years. It's still holding on. But if you don't, a graft like this will not work, and the patient start using the index and the middle finger as a cigarette grip. There was this patient with a thumb which was poorly developed, but index had a complex syndactyly. So what I decided, I'm going to split this into two, and this half was transferred on top of this one. I don't know. So this was transferred on top of this, and sure enough we had more length. So what began like this ended up here. So in summary, the problem is when the newborn is there, you say you grow up, then you come, and this is a bad advice, and therefore the best time to offer for surgery is the first year of life, maybe second year. Beyond that is getting too long.